Back. We're about to have two talks that are very sort of similar in topic. They have to do with reproduction and NF and also the genetics of NF. So I think these will be really interesting. I'm looking forward to them too. So the first talk is going to be given by Heather Radtke, who is a certified genetic counselor with 20 years of experience as a genetic counselor and 16 as a genetic counselor specifically for NF. She's so obviously very knowledgeable about counseling people with NF, and I'm very happy to have her join the CTF team. She's going to be the clinic and symposium coordinator going forward. So if any of you have questions about clinics, she would be the person to contact. Oh, and she's also written a very good booklet called Just for Teens, which you may have seen out in the lobby. And if you, I think they're about out of copies, so if you would like to get another one for yourself, you can contact either Heather or myself. We're in the back under staff information. Okay, ready?
Okay, great. I am very happy to be here today. And we have a lot to get through in this 30 minutes. I could probably talk about genetics for a couple days, so I will try to keep it brief and concise and things that you want to know about. So I'm going to be talking about genetic testing for NF. Generally throughout my talk, when I say NF, that means NF1, NF2, and schwannomatosis. So unless I specify NF1, NF2 or schwannomatosis individually, I'm just going to lump them all together as NF. So here's an overview of my talk. I'm going to talk about the clinical versus genetic diagnosis, a little bit about genetics background, specifically about genetic testing, which is our goal today, including pros and cons, and how to decide whether to have genetic testing. So a clinical diagnosis is based on what we can see in clinic. So evaluations such as MRI, eye exams, hearing test, pathology results, that all plays into a clinical diagnosis. What we're mainly going to be focusing on today is the genetic diagnosis. So the genetic testing that involves submitting a sample, either a blood sample, tumor, skin sample, sending it to the lab, and doing the DNA testing off of that. So again, the clinical diagnosis is our famous checklist that we have. Most of the time, this is all we need to make a diagnosis. So we don't even need to go on to genetic testing. It is oftentimes, that's why we have these checklists. They're very straightforward, and that's how we make a diagnosis. The genetic testing, the process is that we obtain the sample, we have families sign consent so that they know what they're getting into. The sample is sent to the lab. So before kind of jumping into DNA testing, I'm going to give you a genetics 101 just to make sure we're all on the same page because it's so fun. So we know that we have trillions and trillions of cells. Within each cells are our set of chromosomes, and chromosomes are a big, long strand winding DNA, and each segment of DNA is a gene. Genes are our body's instructions, our recipes, tell our bodies how to grow, how to develop, what we look like. So genes are kind of the main building block. Genes make proteins, and so the proteins have different functions throughout the body. So we have a total of 30,000 different genes that code for many different things. Most of our genes come in pairs. We get one from mom, one from dad. And a gene, I like to think of a gene as a very, very long sentence. And so it's made up of different letters, and it has a meaning. And it codes for a protein that has a very important function in the body. So when we talk about the NF group of disorders, we know that the NF1 gene is on chromosome 17. So here's a set of our chromosomes. Here's our two pair of 17s. And the NF1 gene is on 17. The protein is called neurofibromin. NF2 gene is on chromosome 22. And that protein is called Merlin. And then we're still sorting out schwannomatosis. It's kind of not as straightforward as the other two at this point. There's two genes that have been implicated and suspected to be involved in schwannomatosis, and we have the protein here. And that is also thought to be right alongside the NF2 gene. And a gene mutation is a change in that long sentence. And so it's a change in the code or in some of the letters. And so we have a normal strand here, and here's a gene mutation. We don't always know why these gene mutations happen. That's the biggest question I wish we could answer, so we could try to prevent some of these. These gene changes also lead to different types of cancers, all different types of disorders, so it's not unique to NF1. With NF1, the proteins with all types of NF, the proteins are tumor suppressor genes and proteins. And so the genes are supposed to suppress the growth of tumors. And if there is a mutation in one of these genes, that is not inhibited, and so we get tumor development. Now, of course, we heard earlier today that neurofibromin, the protein, also has many other functions that we still don't know about, but we know for certain that all of these genes, NF1, NF2, and the SMARCB1, all have a tumor suppressor function. The inheritance of NF, I believe you might already know about, is dominant. So you only need one copy of a changed gene in order to have it. The other copy is felt to be normal. So if someone has it over here marked with the little orange thing, they would have a 50-50 chance of having a child with NF. And it's basically like flipping a coin. So every single child is that 50-50 chance. So it doesn't mean that if you have 4 kids, 2 will have it, 2 will not. By chance that might work out, but it could be all heads, all tails, or any combination, so every time. NF is also extremely variable, as we all know, but it does not skip generations. And so there might be a mild parent. It might appear as though it skips generations, but we know it doesn't. We pass those genes from one generation to the next. So here's what we do in genetics is we draw out different types of family trees. And so these are showing different generations. And so here are grandparents and male, female, child. So these would be parents, children, grandchildren. So different generations. We know that NF about half of the time can be inherited from a parent, so it can run clearly through the family. And the other half of the time, it can be a brand new condition in the family. So it's about a 50-50 chance. So we have people come into clinic all the time that say, I don't have a family history of NF, I can't have NF. We know that that happens very frequently. So let's talk about the process of DNA testing. So there are many different labs throughout the world that do DNA testing. They vary slightly by their techniques, some of their detections rates depending on their techniques, cost, turnaround times. They may include testing for other genes other than the NF gene, if there's different panels or a number of genes that might be tested, just depending on what the physician feels like they need to order or look at. What the lab does is from the specimen they receive, the blood test is the most often form. They isolate the DNA, or else an alternative form of DNA is called RNA, and they proofread that gene. So going back to our sentence analogy, they look for any kind of misspellings, extra words, any kind of rearrangements that can happen within that long sentence. And then the hardest part is actually analyzing that, because we know that many of us have missing words, extra words, and that's part of our normal variation. That's just part of being human and makes us unique. And so the lab is responsible for determining, well, is this missing word really a problem and causing the condition, or is it just part of normal variation? And so sometimes that interpretation can be a little difficult. So the money that it costs for genetic testing is well deserved by the labs. And then the result usually comes back within 4 to 6 weeks. So when we talk about NF1 gene mutations, there's more than 1,000 different ways that you can change that gene that can cause NF. And so oftentimes we have not seen it before. It's unique to a family. And so we're still learning a lot about this gene. NF2, there's more than 200 different types of mutations. Many of them result in a shortened protein or a shortened sentence. And there are different detection rates depending on the technology and things like that. I'm going to get into that a little bit later. But depending what gene we're looking at, genetic testing, unfortunately, is not perfect, even though we like to think it's a nice, straightforward yes or no answer. What we know is that in people who have a definite diagnosis of NF type 1, 97% of the time we're able to pick up their genetic change. So if you flip that around, that means 3% of people that we know have NF1 are missed by this test. So it's not a huge number, but we know that it does miss some people. So we say the detection rate is very, very good, but not 100%. For NF2 and schwannomatosis, it goes down even a little bit more. So for NF2, if you're the first person in the family to have NF2, the detection rate for for testing is about 70%. And I'm going to explain this reasoning in a little bit why it's different here. But if you're the second person in the family, so there's familial, where it's inherited, the testing is much better at 90% of being able to identify those genetic changes. And then schwannomatosis, we have a lot to learn, and so those detection rates are a lot lower. So with NF1 mutations, what makes it difficult is when we look at the sentence, we look for the different genetic, the changes in our sentence. It doesn't seem to be that there's what we call a genotype-phenotype correlation, where we can say, okay, this person has this word missing. What is their symptoms? What are their symptoms going to be? So we can't take that information and say, this is how severe it will be. This is when they'll develop a tumor. This is that. And that's what we call genotype-phenotype correlation. We like to give answers, but in NF1 mutations, we really can't. We see it all over the board. So, and that's why we see, even in families, we see tremendous variability between parent and child, grandparent. Everyone with NF, even within the same family, can be quite different as far as how the spectrum of severity that we see. The only two exceptions that we really know about are individuals who are missing the entire gene of NF. That's called a microdeletion or NF1 deletion. Those individuals, because they're missing that entire sentence, actually have a more severe symptomatology. So they have more significant learning disabilities, earlier onset of neurofibromas, and other things that can go along with that. The other case is when we see a small little tiny word, it's called an AAT deletion, that individuals with this small word missing have a more milder presentation. And they usually have pigmentation anomalies, but not any of the neurofibromas or tumor development that we can see. So just to give you a context of how frequently we see this, the gene deletion we see in about 5% of people that have NF1. The AAT deletion we really don't see all that often. And so even though we hope we would find it, because it does say that it's going to be a milder phenotype, we really don't see it all that often, but we do know it exists, and it does seem to stay the same even throughout different families. With NF2, it's slightly different. There's a little bit better of a genotype-phenotype correlation. There's some gene mutations that are more severe and tend to present that way, and others that are more mild. So you can look at how the gene is changed, and you can make kind of more generalizations. Definitely not predictions, but generalizations. Also, what makes NF2 a little bit more unique is that the severity seems to be the same in the family. So if you have a parent who is more mildly affected, the chance that you would have a child who's mildly affected is greater. Whereas NF1, it's all over the board. NF2, it tends to breed a little bit truer. So why is there variability in NF? I wish we could answer this question. We think that perhaps the type of genetic change that we see affects the protein, so somehow that must be tied in, but we know that there's a ton of other things that must also be influencing things. So whether there's other modifying genes or other factors that we don't know about, whether there's environmental factors, I think there's a lot of efforts and research going in to try to identify some of these so that we can try to reduce the impact that NF would have. When we get results of genetic testing, we have three possibilities. One is positive, which means that we found the answer, we can confirm the diagnosis. Negative is we haven't found anything, and I'm going to give some examples of when we would find that result. And then the inconclusive is the one that I said, we look at that long sentence and we see something wrong, but we don't really know if that means anything or not. And so fortunately, it doesn't happen a lot, but we know that sometimes that happens. It can be very frustrating as a family to get an inconclusive result. We like answers, right? All right, so reasons for a negative test might mean that it's not NF. And so that tells us that either it's not the condition we were looking for, or it's another condition that might look like NF. And so it might be something that causes the cafe au lait spots. We know that there's another NF-like syndrome called Legius syndrome that's caused by a SPRED1 mutation. We know that there's always been limitations in technology and knowledge. So even with NF1, we've known about that gene for a long time. The testing is very good at 97%, but we're not picking up 100%. So we know that there's definitely things out there that we don't know about. And then the last situation is mosaicism, which is a little bit hard of a concept to understand, so I'll try to go through it. Normally, when we have NF, so here's showing a sperm and an egg coming together, forming a zygote, and then what happens is cells multiply and multiply and multiply, and then you have a person. So what usually happens in NF is either the egg or the sperm is the one that has the genetic mutation, and then the cells keep dividing, and then all of the cells in the person have the genetic change. What happens when we have mosaicism is that genetic change happens later in development. And so after some of the cells have already started dividing, it happens later. So then what we get is we get this mixture of normal cells and mutated cells. And so then the person kind of has some cells that have the NF change in it and some cells that are the typical normal cells. So when we do genetic testing on this person, let's say we do a blood test, well, if their blood cells are not part of the area that's affected, we're going to get a negative test. Okay, does that make sense? And so what we know is that happens actually quite often in NF type 2, is that people are mosaic. When they're the first person in the family, they're mosaic, and that's why those detection rates are different. When you're testing for NF2, the first person in the family might be mosaic, and so we might not pick up as many cases. But then once it's in the family, then it's in every cell of their body, and so then we have a higher detection rate. With NF1, we can also see this mosaicism. Most often, it leads to a bunch of changed mutated cells in one area of the body, and it's called segmental NF. And so it's confined to one area of the body. And so these can be reasons why somebody might get a negative test. It doesn't take everything off of the table, but it reduces the chance that we might be dealing with NF. So some reasons to consider genetic testing include confirming a diagnosis. So for instance, if the clinical diagnostic criteria, the checklist that we talked about at the beginning, maybe a person is too young and they haven't met that second criteria. Maybe it's just not straightforward. We can do genetic testing to absolutely confirm that someone has NF. Also, I think we're going to be learning more and more about NF, and so genetic testing might help us get there. We know that genetic testing can also help us test other family members or used to be for prenatal testing. So prenatal testing obviously is during a pregnancy, where we can do amniocentesis or chorionic villus sampling, which is sampling of the cells around the baby to determine if the baby has NF. And then that information can be used for planning for the pregnancy. There's also, I call it newer, but it's really not new anymore, probably about 15 years old or so, a technique called pre-implantation genetic diagnosis. It's kind of like an in vitro procedure where you take the egg and you take the sperm, you fertilize them together almost like in a test tube. And then as the cells divide, you can remove one of those cells, you can test it for the genetic change that's in the family. And if the genetic change is not there, then you implant that into the woman. And so it really does reduce the risk of having a child with NF. Some things to remember about testing, especially if you're considering testing pregnancies or family members, is we need to always consider, we have to start with the person in the family that we know has NF. And so we need to know that that person's genetic mutation can be identified with today's testing. So we need to know that they fall into that 97% for NF1 that actually is able to be picked up. Because if they fall into the 3%, then we're not going to pick it up in any relatives either, even though they might have it. We also have to consider the timing of the testing and when families want the results back. And then also, even if we identify somebody has one of the genetic mutations, we know that there's a lot of variability, so we cannot make predictions based on the genetic test results in many cases. So we might be able to say, yes, your baby has NF, but we won't be able to say what complications they may or may not have. So some of the limitations before we cross that testing line that we need to make sure people know about is that it doesn't detect all cases. We've talked about that. Change the clinical diagnosis. So we're still going to go back to the clinical criteria. And then it cannot predict the severity of the disorder. So some additional things to just kind of consider if you or your family are thinking about doing genetic testing is if it will help make a diagnosis, if it will help you accept the diagnosis. Some families we see early on, don't believe that their child has NF and feels like they do want to go ahead and do the test and get that paper confirmation that they have it. And that's perfectly acceptable. Will it change medical management of the patient? Will it help any other family members? Of course, the biggest question it seems to be these days is, will insurance cover it? In general, if it's to make a diagnosis that might impact medical management, it is a covered benefit under most insurance companies. How would you feel if there's a negative result, a positive result, or inconclusive? So we always have to think through those possibilities before we do testing. And then who should be informed of these results, and kind of thinking through, well, who would I share these results with, or who do I need to? And so for additional guidance, you can always consult with a genetic counselor to talk more about genetic testing. Many clinics throughout the country are doing genetic testing, many are not. And it's kind of up to the physician who's caring for the family. It's not like there's a right or wrong answer. It's something that each family has a choice and an option to move forward with and see if they might benefit from it. Okay, thank you very much.